Thank you for kind introduction. My name is Minkwan Kim. Good afternoon, everyone. My name is Minkwan Kim. I'm cardiologist, and I'm from Yonsei, Yonsei Hospital, based at Yonsei University College of Medicine. Today, I will discussing strategy for managing high blood pressure to prevent CVD with Fimasartan. I will proceed with the presentation with the following contents. In Korea, the prevalence of heart failure has risen significantly, reaching 2.6% in 2020. Along with this increase, hospitalization rate for heart failure and mortality rate also increased. In Korean heart failure patient, hypertension is the most common comorbidity, affecting 78.7% of patients. It's significantly higher than other conditions like diabetes and ischemic heart disease. Hypertension-mediated organ damage, or HMOD, refers to structure or functional changes in large and small arteries or end organs, and caused by elevated BP. And HMOD is a marker for preclinical or asymptomatic CV or kidney disease. Right figure shows that the higher the severity of hypertension, the greater the prevalence of HMOD. And the presence of HMOD is associated with poor cardiovascular outcomes. This is cardiovascular disease continuum. Hypertension, along with other risk factors such as dyslipidemia, contribute to the development of atherosclerosis, which can lead to coronary artery disease. Also, the increased afterload from high blood pressure can cause left ventricular hypertrophy and both systolic and diastolic dysfunction. Elevated systolic and diastolic blood pressure is a strong predictor of future cardiovascular events, including cardiac death, myocardial infarction, stroke, and heart failure. This data from 290,000 untreated patients from Korean NHIS data published in 2019 in European Heart Journal. And this is show that clear correlation where both systolic and diastolic blood pressure are associated with increased risk of these cardiovascular outcomes. This slide shows that the progression from hypertension to heart failure. Right side is staging of hypertensive heart disease. Stage 1 is only LV diastolic dysfunction, and stage 2 is LV diastolic dysfunction plus LV hypertrophy, and stage 3 with clinical heart failure with presence of clinical symptom or sign of heart failure with preserved LV ejection fraction. And the end stage of heart failure, hypertensive heart disease, usually the result of long-standing pressure and overload consists of dilated cardiomyopathy with both diastolic dysfunction and reduced ejection fraction. In optimized heart failure registry, hypertension etiology was more common in a patient with preserving systolic function than patient with LV dysfunction. And also, etiology of heart failure is more common in HFpEF than HFrEF. This suggests that hypertension is more common underlying cause in heart failure patient with preserved ejection fraction. A similar trend is observed in Korean acute heart failure or core AHF registry. In this data, hypertensive etiology is more common, or 64%, compared to 56% in those with HFrEF. This slide shows a meta-analysis of 123 large-scale BP lowering trials published between 1966 and 2015. The analysis demonstrated that for every systolic BP, 10 milliliter of mercury reduction is then there is 20% reduction in major CV event and 28% reduction in heart failure. This slide shows the relationship between BP and mortality in patients with heart failure based on 5,600 patients hospitalized for acute heart failure in Korea. This is observational study, and the primary endpoint was all-cause mortality. The nadir in BP is different in HEP and HEP-REP. HEP is nadir of blood pressure is 136, but in HEP patient, the hazard ratio nadir is lower than HEP-REP of 127. This is prognostic value of BP according to heart failure ejection fraction. HEP has a narrow margin of safety as higher blood pressure is associated with increased risk in HEP compared to HEP-REP. In green zone, representing low-risk blood pressure range, HEP patients have a tighter range compared to HEP-REP. Well known for its impact, the SPLINT trial shows that intensive BP treatment reduced the primary outcomes by 25% compared to standard treatment. In this trial, intensive treatment group had a low rate of heart failure, about 38% risk reduction, and event of death from cardiovascular cause also significantly decreased. The STEP trial, often referred to as Asian SPLINT, is a well-known study that demonstrated better cardiovascular outcome in elderly hypertensive patients who received intensive treatment targeting systolic blood pressure below 130. This slide outlines the 2022 guideline in both KSHF and KSH, focused on intensive BP rolling with a target of systolic BP below 130. In KSH 2022 guideline, the target blood pressure of 130 is recommended for patients at high risk of heart failure, as well as those with HEP-REP with hypertension. In the ESC 2024 guideline, intensive BP treatment for hypertension patient aims for systolic BP between 120 to 129, as low as reasonably achievable. This target is recommended for most patients with diabetes, moderate to severe CKD, previous stroke or TIA, or cardiac disease. Same guideline, it's also recommended that heart failure patients to target systolic BP below 130 and diastolic blood pressure below 80. In 2024 European guideline, role of ARB has quite decreased in HEP-REP and HEP-MREF, but they remain an available option. For HEP patients, ARB may be considered to reduce heart failure hospitalization and lower blood pressure. In 2022 Korean Society of Hypertension guideline, the recommend antihypertensive drug by conditions table indicate that ARB are recommended for hypertension management in many conditions, including heart failure. And in case of combination therapy, it's recommended to use combination ARB with CCB and diuretics. Both KSH and ESH guideline, single pill combination therapy is recommended, particularly ACE or ARB with CCB or diuretics, and progressing to triple combination therapy if needed. Also in ESH guidelines, single pill combination therapy recommended. A low-dose double and then triple combination strategy while monitoring tolerance among patients with hypertension and only afterwards to start up titrating dose to maximize amount. Now I will talk about the drug Fimasartan. What consists an ideal antihypertensive drug? It should provide excellent BP lowering effect and safety, offer 24 hours coverage, and proven organ protection effect, and proven efficacy in reducing cardiovascular and renal outcome. Fimasartan has a strong binding affinity to the AT1 receptor, resulting in highest association rate among ARBs, about 12 times faster than valsartan. Additionally, it has lowest dissociation rate with dissociation half-life of 63 minutes, about 16 times more than losartan. Strong BP lowering efficacy of Fimasartan compared to other ARBs in head-to-head studies. On the left, Fimasartan demonstrates a great reduction in sitting SBP at 8 weeks compared to losartan. Fimasartan also outperforms candesartan, achieving about 12 millimeter of mercury reduction versus candesartan. And right side is Fimasartan is compared with valsartan and about 34% BP reduction than valsartan. For cardiovascular disease prevention, this study compares the long-term effect of 7 ARBs, including Fimasartan, on all-cause mortality and major adverse cardiovascular events. Among 7 ARBs, Fimasartan demonstrates the lowest incidence of MACE and all-cause mortality. This data highlight Fimasartan's potential benefit for cardiovascular protection in patients at risk. For high-risk hypertension, ARB and CCB combination therapy is recommended. This strategy improves endothelial function, provide a nephroprotective effect, and reduced amlodipine-induced edema, and achieved significant BP reduction. It targets different hypertension types, including stiffness-related and volume-related tension types, ensuring optimal 24 hours control and cardiorenal protection. DUCAB is a combination of ARB and CCB developed by Boryong Pharmaceutical. In a phase 2 clinical trial, DUCAB demonstrated a strong blood pressure reduction effect, achieving up to 34 millimeter of mercury decrease in systolic BP by week 8 from baseline. Compared to monotherapy with either amlodipine 10 milligram or Fimasartan 60 milligram, DUCAB has shown response rate of up to 89%. About 25% of patients do not reaching target BP with dual therapy. For patients who fail to achieve blood pressure control with dual combination therapy, then triple combination of ARB, CCB, and diuretics is recommended. Combination therapy with CCB, ARB, and diuretics offer additive blood pressure lowering effect. CCB increase arterial vasodilation, and ARB reduced vasoconstriction, and diuretics support acute natriuresis and long-term reduction in total peripheral resistance, together enhancing overall BP lowering efficacy. In high-source-sensitive hypertension, hydrochlorothiazide diuretics significantly reduce nocturnal blood pressure, especially effective for non-dipper. The DCP trial shows that there is no difference in the efficacy outcomes for composite endpoint and hypokalemia, but there is higher instance of hypokalemia with clostridone compared with hydrochlorothiazide. Duca Plus demonstrates strong BP lowering efficacy with reduction of 19 millimeter of mercury in patients who don't achieve target BP on Duca. And small tablet size improved compliance, supporting long-term blood pressure control. It combines Fimasartan, amlodipine, and hydrochlorothiazide available in various dosage options to suit patient needs. I introduced my case. This is a 41 woman with chest discomfort and epistaxis via ER. And initial her BP was 238. And ECG shows LVH, and in parasternal long and short axis view, concentric LVH was seen. I give some Ducab to patient, and systolic BP was markedly decreased. 6 months later, LVH was improved, and in follow-up echocardiography, LV posterior wall thickness is markedly decreased from 14 to 8 millimeters. Ladies and gentlemen, this is take-home message. High blood pressure is a cause of CV event, and BP management is required to prevent heart failure. Intensive BP below 130 control is recommended in cardio-cerebrovascular risk factor. Single pill combination therapy is recommended from all steps and the beginning of the initial treatment. Thank you for your attention.